This recording will cover gastritis. Gastritis is the inflammation of gastric mucosa, or the stomach lining. Prostaglandins usually provide a protective mucosal barrier that prevents the stomach from digesting itself in a process called acid autodigestion. If there's a break in that protective barrier, mucosal injury occurs. The resultant injury is worsened by histamine release and vagus nerve stimulation. Hydrochloric acid can then diffuse back into the mucosa and injure small vessels. This back diffusion causes edema, hemorrhage, and erosion of the stomach's lining, which alters immunity. The pathologic changes of gastritis include vascular congestion, edema, acute inflammatory cell infiltration, and degenerative changes in the superficial epithelium of the stomach lining. Inflammation of the gastric mucosa and submucosa after exposure to local irritants or other causes can result in acute gastritis. The early pathologic manifestations of gastritis are a thickened, reddened mucous membrane with prominent rugae or folds. Diagnosis cannot be based solely on clinical symptoms. If the stomach muscle is not involved, complete recovery usually occurs with no residual evidence of gastric inflammatory reaction. If the muscle is affected, hemorrhage may occur during an episode of acute gastritis. Chronic gastritis appears as a patchy, diffuse, or spread out inflammation of the mucosal lining of the stomach. As the disease progresses, the walls and lining of the stomach thin and atrophy. With progressive gastric atrophy from chronic mucosal injury, the function of the parietal or acid-secreting cells decrease, and the source of intrinsic factor is lost. Intrinsic factor is critical for the absorption of vitamin B12. When body stores of vitamin B12 are eventually depleted, pernicious anemia results. Chronic gastritis is associated with an increased risk for gastric cancer. The persistent inflammation extends deep into the mucosa, causing alteration in immunity by destruction of the gastric glands and cellular changes. The onset of infection with Helicobacter pylori can result in acute gastritis. H. pylori is a gram-negative bacterium that penetrates the mucosal gel layer of the gastric epithelium. Long-term NSAID use creates a high risk for acute gastritis. NSAIDs inhibit prostaglandin production in the mucosal barrier. Other risk factors include use of alcohol, coffee, caffeine, and corticosteroids. Acute gastritis is also caused by local irritation from radiation therapy and accidental or intentional ingestion of corrosive substances, such as acids or alkalis, such as lye or drain cleaner. Type A gastritis has been associated with the presence of antibodies to parietal cells and intrinsic factor. Therefore, an autoimmune cause for this type of gastritis is likely. Parietal cell antibodies have been found in most patients with pernicious anemia, and in more than one-half of those with type A gastritis. The most common form of chronic gastritis is type B gastritis, caused by the H. pylori infection. The host response to the H. pylori infection is activation of lymphocytes and neutrophils. Release of inflammatory cytokines damage the gastric mucosa. Chronic local irritation and toxic effects caused by alcohol ingestion, radiation therapy, and smoking have been linked to chronic gastritis. Surgical procedures that involve the pyloric sphincter, such as a pyloroplasty, can lead to gastritis by causing reflux of alkaline secretions into the stomach. Atrophic gastritis is a type of chronic gastritis that is seen most often in older adults. It can often occur after exposure to toxic substances in the workplace, or an H. pylori infection, or it can be related to autoimmune factors. Atrophic gastritis can lead to two types of cancer: gastric cancer and gastric mucosa-associated lymphoid tissue lymphoma. A balanced diet, regular exercise, and stress reduction techniques can help to prevent gastritis. Limiting the intake of food and spices that cause gastric distress, such as caffeine, chocolate, mustard, pepper, and other strong or hot spices, can help. Alcohol and tobacco should be avoided. Regular exercise maintains peristalsis, which helps prevent gastric contents from irritating the gastric mucosa. Stress reduction techniques can include aerobic exercises, meditation, reading, or yoga. Excessive use of aspirin or other NSAIDs should also be avoided. If a family member has an H. pylori infection or has had it in the past, patient testing should be considered. This test can identify the bacteria before they cause gastritis. Please review Chart 55-1 for patient education regarding gastritis prevention. Symptoms of acute gastritis range from mild to severe. The patient may report epigastric alterations in comfort or pain, anorexia, cramping, nausea, and vomiting. Assess for abdominal tenderness and bloating. Also assess for hematemesis and melena. Symptoms last only a few hours or days and vary with cause. Aspirin or NSAID-related gastritis may result in dyspepsia. Gastritis or food poisoning caused by endotoxins has an abrupt onset. Severe nausea and vomiting occur within 5 hours of the ingestion of the contaminated foods. In some cases, gastric hemorrhage is the presenting symptom, which is a life-threatening emergency. Chronic gastritis has few symptoms unless ulceration occurs. Patient may report nausea, vomiting, or upper abdominal discomfort. Periodic epigastric pain may occur after a meal. Some patients have anorexia. Please review Chart 55-2 for key features of acute and chronic gastritis. EGD is the gold standard for diagnosing gastritis. A cytologic examination of the biopsy specimen is performed to confirm or rule out gastric cancer. Tissue samples can also be taken to detect H. pylori infection using a rapid urease testing. Acute gastritis is treated symptomatically and supportively because the healing process is spontaneous, usually occurring within a few days. When the cause is removed, pain and discomfort usually subside. If bleeding is severe, blood transfusion may be needed. Fluid replacement is prescribed for patients with severe fluid loss. Surgery may be needed for patients with major bleeding or ulceration. Treatment of chronic gastritis varies with the cause. The approach to management includes the elimination of causative agents, treatment of any underlying disease, avoidance of toxic substances, and health teaching. Eliminating the causative factors such as H. pylori infection, if present, is the primary treatment approach. Drugs and nutritional therapy are also used. In the acute phase, the primary healthcare provider prescribes drugs that block and buffer gastric acid secretions to relieve pain. H2 blockers, such as famotidine, decrease gastric acid secretions by blocking histamine receptors in the parietal cells. H2 blockers are given at bedtime for the treatment of GI ulcers, heartburn, and peptic ulcer disease. Sucralfate is a mucosal barrier fortifier that protects the stomach mucosa. It is given 1 hour before or 2 hours after meals. It's given 1 hour before and 2 hours after meals and at bedtime. It's important to make sure that the patient takes the medication as directed because food may interfere with the drug's adherence to the mucosa. Sucralfate acts as a band-aid for any sore areas in the stomach. And so for that sucralfate to actually get to that sore area and coat the stomach, it has to be given when there's not food present in the stomach or else it can't do its job. Do not give within 30 minutes of giving antacids or other drugs. And remind the patient to refrain from taking aspirin while on this drug. Aspirin is a salicylic acid that can lead to an overdose. Oh, I'm sorry, that is for the Pepto-Bismol. The bismuth subsalicylate is also a mucosal barrier fortifier, and you want to advise the patient taking Pepto-Bismol or the bismuth subsalicylate not to take aspirin while taking the Pepto-Bismol. Antacids work to increase the pH of gastric contents by deactivating pepsin. Magnesium hydroxide with aluminum hydroxide and aluminum hydroxide are the two examples listed on your drug chart. For magnesium hydroxide with aluminum hydroxide, give 2 hours after meals and at bedtime. Do not give other drugs within 1 to 2 hours of antacids. Assess renal function when the patient is taking the medication. And observe the patient for the side effect of diarrhea. Magnesium often causes diarrhea. For aluminum hydroxide, Give 1 hour after meals or at bedtime. So for both of these antacids, a huge patient teaching thing is when they're supposed to take the medicine, because a lot of patients will take their antacid with the meal, and it's not effective if they're doing that. So for aluminum hydroxide, give 1 hour after meals or at bedtime. Hydrogen ion load is high after ingestion of food. Use liquid rather than tablets if possible. Do not give other drugs within 1 to 2 hours of antacids, obviously. Observe for the side effect of constipation. Aluminum can cause constipation, and also monitor kidney function. Proton pump inhibitors work by reducing stomach acid production. Omeprazole is one of those medications. It should be given 30 minutes before the main meal of the day. The proton pump is activated by the presence of food, therefore the drug needs a chance to work before the patient eats. Pantoprazole is another medication that you will use frequently in the clinical setting because it can be given by IV. And it's important to know not to give Protonix IV with other IV drugs because the IV form is not compatible with most other drugs. Teach the patient to monitor for symptom relief and side effects of drugs used to treat gastritis and to notify the primary healthcare provider of any adverse effects or worsening of gastric distress. The dose, frequency, and type of drug may need to be changed if symptoms of gastric irritation appear or persist. Remind patients not to take additional over-the-counter drugs such as Pepcid if they are taking similar prescribed drugs. Patients with chronic gastritis may require vitamin B12 for prevention or treatment of pernicious anemia. If H. pylori is found, the primary healthcare provider treats the infection. The patient should be taught to avoid drugs and other irritants that are associated with gastritis episodes. These drugs include corticosteroids, erythromycin, and NSAIDs. Teach the patient to limit intake of any foods and spices that cause distress, such as those that contain caffeine or high acid content, such as tomato products or citrus juice, or those that are heavily seasoned with strong or hot spices. Bell peppers and onions are also commonly irritating foods. Most patients seem to progress better with the bland, non-spicy diet and smaller, more frequent meals. Alcohol and tobacco should also be avoided.